to us about inpatient care, adult inpatient for COVID-19 patients, how they manage their patients in Seattle, USA. So welcome to today's session. Sorry, I forgot to introduce myself. My name is Dr. Rhoda Kalondo from Kenyatta National Hospital. My co-host is Dr. Nancy Ngumbao. She will be handling the session after this. And also my other colleague is Dr. Rosa Chemwei, who will also join us as the session continues. So thank you so much. And I'd like to also thank the person who's just commented in the Q&A section. We are glad that you've gained a lot. Thank you. Thank you very much for that feedback. Please remember to put your questions, concerns, comments in the Q&A section, and we'll be able to address them as the session continues. Dr. Johnson?
Yes.
Yes, would you like to start the session?
Absolutely. Thank you very much for inviting me to be here with you all. It's truly an honor. I'm excited to talk to you all a little bit about our experience caring for inpatients with COVID-19 in Seattle, USA. My experience is mainly limited to the intensive care setting, but many of the things I'll discuss today generalize to a lot of different settings and have evolved quite a bit over the past 3 months. As many of you might know, Seattle, Washington was the first region of the United States really affected by COVID-19, with the first case here in the US all the way back in February. So we, perhaps more than other regions of the United States, had a little bit more time to prepare and think about our inpatient treatment protocols. And even despite that, our approach has really evolved, as you'll see over the past several months. I don't have any conflicts of interest. I am an investigator on one of the hydroxychloroquine randomized control trials that's ongoing right now called the ORCHID trial, and I'll talk briefly about that. And I do have research funding from the National Institutes of Health and the Medic One Foundation. So my goals today are really threefold. First, I hope to convince you all that COVID-19 really leads to a wide spectrum of critical illness, including fairly typical acute respiratory distress syndrome. And this has been the subject of quite a lot of debate. I'd like to review our evolving approach to respiratory support in COVID-19 and talk to you about how our thoughts and approaches have changed over the past 3 months in caring for these patients. And then finally, we'll spend a little bit of time talking about the experimental pharmacotherapy and some of the early clinical trial data that's starting to emerge, and also how our approach to using different pharmacotherapies have evolved over the past several months as well. So first, let's start with a case. This is a fairly typical patient that we'd seen over the past 3 or so months. This is a 32-year-old healthy woman who presented to one of our emergency departments with a complaint of cough. When she arrived, she was febrile to 38.5 degrees and tachycardic to 110 beats per minute. She had a normal blood pressure, was mildly tachypnic with a respiratory rate of 20, and was quite hypoxemic, perhaps disproportionately so compared to the rest of her vital signs, with a saturation of 66% on ambient air. This case, I hope, highlights what we think are the phases of critical illness in COVID-19. The initial phase, characterized by acute hypoxemia, is notable for profound shunt physiology, which we think is due to alveolar filling from direct alveolar injury. And this causes pretty classic shunt physiology with a widened arterial alveolar oxygen difference and a minimal response to supplemental oxygen, fairly characteristic of shunt physiology. These patients also have quite profound exertional hypoxemia and follow an unpredictable course. Some will improve after this acute phase, and others will progress to the next phase, characterized by the acute respiratory distress syndrome, or ARDS, as well as multi-organ failure. These patients will often have a mild, kind of low-grade distributive shock with a persistent vasopressor requirement, a wide spectrum of cardiovascular abnormalities that have been described, ranging from a mild myocardial injury and a slight elevation in troponin, all the way to frank myocarditis and cardiogenic shock. Various forms of coagulopathy have been described, as well as a direct viral mediated acute kidney injury and acute hepatitis that's common in critically ill patients. And the final phase we're just learning about, which is the prolonged critical illness phase. And this is the phase that's a consequence of many of these patients in our hospitals spending weeks to sometimes even months in intensive care. These patients have secondary bacterial infections, perhaps related to prolonged critical illness and being compromised for a long period of time. A number of other ICU-related complications like venous thromboembolism and blood clots, profound weakness related to deconditioning and immobility, and perhaps post-traumatic stress disorder, which is a known complication of prolonged critical illness that we're just starting to learn about in COVID-19. Our approach to respiratory care for these patients has really evolved over the past 3 months. At the beginning of this period, where we were first starting to see patients with COVID-19, our approach to respiratory care really hinged on very early intubation and mechanical ventilation. And we had an early clinical guideline that recommended intubation for any patient on greater than 6 liters oxygen via nasal cannula. The reasons for this were severalfold. First, we were hearing reports from our colleagues in China and Europe that patients with COVID-19 and severe respiratory distress often had precipitous respiratory failure that was unpredictable. And so we used this strategy of early intubation to try to preempt rapid respiratory failure. The second concern we had was related to protecting healthcare workers, and we thought that perhaps by intubating early and putting patients on a closed ventilator circuit, there might be lower risk of contamination of the environment and healthcare workers becoming ill. As more and more data has emerged from the US and China and Europe, we've evolved to sort of where we were before COVID-19, which is that if hypoxemia was the main problem that the patient was presenting with, we would try our usual array of non-invasive devices to improve hypoxemia and only intubate when a patient really needs intubation and mechanical ventilation. And we'll talk a little bit more about some of the other devices that we're using. The main device that we're leaning on most heavily is high-flow nasal cannula. Many of you are likely familiar with this device, but this is a special type of oxygen delivery device that allows us to deliver markedly high flows of oxygen and air. This device uses high pressure and oxygen and high pressure air off of the wall, off of our in-house oxygen store, and it routes that oxygen and air to a blender where we can dial in a specific fraction of inspired oxygen by dialing in a relative proportion of oxygen and air. After the blender, the air oxygen mixture then travels to a humidifier where it's humidified and heated, and then to the patient via large bore tubing and a large bore set of cannulas that occupy almost the entire internal diameter of the patient's nair. There are several theoretical advantages to these devices. The first is that they're able to deliver very, very high flows, often up to 80 liters per minute of flow, which can match the inspiratory flow of patients even in profound respiratory distress. As a result, there's less ambient air entrained around the device because most of what the patient is getting is actually from the high flow device. As I mentioned, you can titrate the fraction of inspired oxygen and flow independently, and we often titrate FiO2 for hypoxemia and flow for dyspnea. And as I also mentioned, it's humidified, and so it's better tolerated by patients. Lastly, these devices are able to provide just a small amount of PEEP, which in adults is likely mostly transmitted to the upper airway, but in children may be 2 to 3 centimeters of water at the level of the alveolus. One of the early questions around using these devices was whether they were safe to use in COVID-19, with a concern around dispersion of respiratory droplets that were laden with virus. This is one of the early experimental studies done around the beginning of COVID-19 that looked at these high-flow nasal cannula devices. And in a mannequin-based experimental model where they simulated cough, they found that the mannequin with simulated cough without high-flow nasal cannula would disperse respiratory droplets about 2.48 meters, and then with the device, there was a negligible difference to about 2.91 meters. Another more recently published study looking at another experimental model, but this time with human subjects and these high-flow nasal cannula devices, measured the density of particles in the ambient environment with or without the high-flow nasal cannula device and with or without a surgical mask placed over the high-flow nasal cannula device. as they used 2 different subjects and measured at different distances, 2 feet and 6 feet. And they found that compared to the control at 30 liters of flow or 40 liters of flow with or without a surgical mask over the device, there was essentially no difference during coughing and without coughing in the density of dispersion of respiratory particles in the ambient environment. So we took these studies and several other experimental models like these to indicate to us that this device was probably safe to use under the right conditions. We are using high flow nasal cannula in patients with moderate hypoxemia and mild distress who don't have hypercarbia because the device does not provide substantial ventilatory support. And we're using it ideally in airborne precautions. For us, that's a negative pressure room with a surgical mask over the patient, at least when we're providing care close to the patient's face. And then we're monitoring the patient very, very closely for any signs of deterioration. Another technique that we're using to improve oxygenation in non-intubated patients is prone ventilation. This is a CT scan from one of the many studies of imaging studies of patients with COVID-19 that shows some of the typical CT scan findings of this disease. And one of the classic findings is very dense dorsal lung consolidation in the subpleural regions. And this is the area of the lung that also tends to be best perfused in the supine position. So we take advantage of the redistribution of blood flow that happens when the patients roll over onto their stomachs, onto their abdomens, and that blood flow tends to redistribute faster than the consolidation will redistribute. And because their ventilation perfusion matching improves, their oxygenation can improve as well. This is an image that some of you might have seen. It was circulating on various social media platforms. This is a patient in a New York City emergency department during the height of COVID-19 there. This is that high flow nasal cannula device that I was referring to. The patient is texting on her phone, is obviously doing somewhat okay if she's able to do that. And she's prone with an oxygen saturation that's reading at 54%, so fairly dramatic hypoxemia in somebody who's awake and able to interact with her smartphone. This is one of the early studies of using this technique in COVID-19. This is a sort of a pilot study in 50 patients in a New York City emergency department. These patients presented with quite profound hypoxemia with a median saturation of 80% at emergency department triage. They had a less than robust response to supplemental oxygen. Their oxygen saturations would go up only to 84% as a median with supplemental oxygen, but after just 5 minutes of proning, they had substantial improvement to 94%. And only 13 of these 50 patients required intubation within the first 24 hours, implying that perhaps this is one technique that we could use to avoid intubation in a subset of patients. Another similar study was published in JAMA just 2 weeks ago in the Journal of the American Medical Association, showed a similar improvement in oxygenation during proning. That improvement was not sustained in all patients, but it was sustained in some. So some patients might have a more robust response than others. And then just as a reminder that this is not particularly new or novel. In fact, it's something we use in intensive care quite often, positioning patients to optimize their oxygenation. This was a study that was published even before COVID-19, showing that in critically ill patients with acute respiratory failure who are not intubated, proning results in improvement in their PaO2 to FiO2 ratio. That's not always sustained after patients return back to the supine position. And that improvement is fairly significant. So putting some of these things together, this is an approach similar to what we're using currently. In patients with hypoxemia as their main presenting problem, the initial technique that we'll try is high flow nasal cannula and awake proning. We'll then monitor these patients closely, and one tool that we're using for monitoring is this ROX index, and this is an index that's been studied, derived, and validated before COVID-19. It's not been studied in COVID. This divides the oxygen saturation by the FiO2, and then all of that divided by the respiratory rate, and a number greater than 4.88 portends low risk for need for intubation. So if patients are doing well, we'll continue to monitor them using this ROX index as well as our general clinical impression of how they're doing. And if they're not looking well by ROX index or just by our clinical impression, those are patients in whom we would consider intubation. We have a limited number of these high-flow nasal cannula devices, even at a large U.S. hospital like mine. And so the backup option that we have is to use continuous positive airway pressure devices with the same awake pronating approach and using the same monitoring approach before we would consider intubation. So unfortunately, our patient that we had discussed previously continues to deteriorate, and by hospital day 7 has developed progressive tachypnea, somnolence, and worsening hypoxemia, and we made the decision to intubate and initiate mechanical ventilation. This is a fairly typical post-intubation chest radiograph for our patients that we're seeing with COVID-19 pneumonia with diffuse bilateral alveolar opacities characterized by these fairly dense consolidations that initially start as subpleural and then progress to often encompass both lung fields completely. So one of the questions that has come up as we're learning more about this disease is whether COVID-19 causes a classic or typical acute respiratory distress syndrome, or ARDS. This was a essentially small case series and opinion piece published back at the fairly early in the COVID-19 pandemic by Luciano Gattinoni and colleagues, where they made the assertion that COVID-19 does not lead to a typical ARDS based on their assessment of the first 16 patients that they'd cared for, who had a mean respiratory system compliance of 50 milliliters per centimeter of water. Just to give everybody a sense of a normal respiratory system compliance. So all of us who have normal lungs sitting here this evening have a respiratory system compliance of around 100 or maybe even higher milliliters per centimeter of water. A typical patient with ARDS has a respiratory system compliance in the 20 to 30 range. And the patients that they described had a mean of 50, though as you can see in this figure, even though the mean was 50, the distribution was quite wide, with some patients out in the normal range and some patients all the way down to as low as 20 or 30. The patients that they described also had a shunt fraction that was quite high, with over 50% of the alveoli, a shunt fraction of over 50%, implying that over 50% of the alveoli were not participating in gas exchange. So just as a reminder about what ARDS is and whether these patients meet the definition, ARDS is defined by 4 criteria according to the Berlin definition, the first of which is acute onset, which has to be within 1 week of an apparent clinical insult like a viral infection. They have to have bilateral opacities on chest imaging that's not explained by other by other processes. All of the COVID-19 patients have this. The opacities can't be fully explained by heart failure or by volume overload. Again, all of our COVID-19 patients, for the most part, meet this criteria. And then they must have hypoxemia, as defined by a PaO2 to FiO2 ratio of less than 300. And then the definition further breaks it down into mild, moderate, and severe ARDS. And in order to meet the definition, these patients need to be on positive pressure ventilation with a PEEP or CPAP of 5 centimeters of water. So virtually every patient with COVID-19 on positive pressure that I've cared for meets this definition, and you'll notice that compliance is not a component of this definition. And the reason for that, according to the original Berlin paper that was published in 2012, is that it's known that in patients with ARDS, the compliance is quite heterogeneous and quite varied from patient to patient. So looking at several studies that have been published both in ARDS before COVID-19 and ARDS after COVID-19, you'll notice a few themes. In these ARDS kind of seminal randomized trials that report compliance, the respiratory system compliance is somewhere around 30 milliliters per centimeter of water in these 4 major ARDS trials. Looking at studies in COVID-19, you'll see The Gattinoni study, which I just mentioned, had the mean compliance of 50 milliliters per centimeter of water, but two others, including one small case series from Seattle and another from Boston, report compliances that look very similar to the previous trials of patients with ARDS, implying that at least some of these patients have lung compliances that look quite similar to ARDS. We also know that, like traditional ARDS, COVID ARDS is quite heterogeneous, and even though the median PaO2 to FiO2 ratio sits around 200, there's quite a lot of variation from patient to patient. And a similar story for compliance. The median sits in the high 30s here in this cohort, with quite a lot of variation from patient to patient. And this is consistent with prior data in ARDS, where we know that compliance, while the average is somewhere between 20 and 30 in patients with moderate to severe ARDS, there's quite a lot of variation from patient to patient. So this is all really consistent with COVID-19 causing a fairly typical ARDS. We're also starting to see pathology data coming back from various parts of the world, documenting pathologic findings from the lungs in patients with COVID-19. And virtually all of them have two common findings. Those are diffuse alveolar damage and deposition of hyaline membranes in the alveolar air spaces. And these two findings are fairly classic for ARDS. We've also seen some other unique features being reported, a lymphocytic versus neutrophilic alveolar infiltration, which we would expect in a viral infection, as well as microthrombosis of the pulmonary vasculature, which we'll talk more about. There have also been some less common findings reported, such as this acute fibrinous and organizing pneumonia, which has been reported in several case reports, autopsy case reports. The pulmonary vascular thrombi have been discussed a lot in COVID-19 because there's a lot of emerging evidence that there might be a hypercoagulable state that goes along with this disease. But I would remind you all that pulmonary vascular thrombi are not new in COVID-19 pneumonia. This is a paper that was published by Dr. Gattinoni himself all the way back in 1988, where he describes 31 patients with severe ARDS, not due to COVID-19, who underwent pulmonary angiography in the intensive care unit. And what he found was that there were multiple pulmonary artery filling defects, implying microthrombosis in 42% of these patients. And 7 out of 9 who had ARDS after traumatic injury had pulmonary arterial thrombosis. So while there may be pulmonary artery microthrombi in COVID-19, this is by no means unique to COVID-19. And we shouldn't necessarily imply from this that our therapies for regular ARDS would be ineffective in COVID-19. So how do we care for patients in Seattle once they're intubated and mechanically ventilated? Well, we provide good evidence-based ARDS care. And really the cornerstone of this is ventilation with low tidal volumes. We follow a protocol that looks quite similar to the ARDS-NET study, the ARMA trial, with tidal volumes of less than or equal to 6 milliliters per kilogram of predicted body weight to target a plateau pressure of less than or equal to 30 centimeters of water on the ventilator. We also focus on conservative fluid management. We'll provide a little bit of fluid resuscitation up front for patients who are hypovolemic, and then very quickly move into early diuresis and trying to keep patients euvolemic to a little bit dry. PEEP titration is deliberate and based on the individual patient's physiology, using a driving pressure or pressure volume loop-based approach. And then for patients who develop refractory disease and have refractory hypoxemia, we will move on to deep sedation using proning, this time in intubated and ventilated patients. And then for refractory hypoxemia, neuromuscular blockade, inhaled pulmonary vasodilators, and extracorporeal membrane oxygenation in very, very select circumstances of patients who have single organ failure, pulmonary only organ failure, and are young and with few comorbidities and likely to survive. So moving on to talk a little bit about some of the pharmacotherapies that we've been using during our time caring for patients with COVID. This is a model that was proposed fairly early on in this disease of the different phases of the viral and host response. The early phase was characterized by sort of this viral response phase where patients had predominantly viral type symptoms like fever, cough, headache, diarrhea, had some fairly classic lab findings, lymphopenia and coagulopathy. And in some patients that would progress to a phase of illness that was dominated by the host inflammatory response. And these would be the patients that would develop ARDS and shock and multi-organ failure. And they would have a hyperinflammatory phenotype characterized by elevations in inflammatory markers and as well as organ dysfunction. It was thought, perhaps, that this early viral response phase would be the time period where patients would benefit most from antiviral specific therapy. And in this late host response phase, patients would benefit most from immune suppression to tamp down their native immune response. Some of the agents that had been discussed have been for the viral response phase, remdesivir, chloroquine, and hydroxychloroquine, as well as convalescent plasma, and later corticosteroids, human immunoglobulin, and various inhibitors of inflammatory cytokines and pathways. Our approach in Seattle has also evolved over time as more and more data has become available. Fairly early in the disease, when we were first developing our clinical protocols, we were participating in the large US randomized trial of remdesivir that was published not long ago. We'll talk more about that trial. We were also using hydroxychloroquine very liberally. Virtually every patient admitted to the hospital was receiving it. And then we were using an interleukin-6 receptor antagonist called tocilizumab for those patients in that late hyperinflammatory phase quite widely early on. As things moved on into April, we were still using hydroxychloroquine. Not much more data had been published by early to mid-April. Remdesivir we were using less and less as the trial had concluded and it wasn't actually available outside the clinical trial for a period of time. Tocilizumab we were becoming more selective with as we started to see some of these patients treated with tocilizumab develop a very high incidence of superimposed bacterial infections later on in their course. And then as we moved into May, we began to participate in a randomized trial of hydroxychloroquine. So patients were receiving hydroxychloroquine only in the context of a trial. We had limited access to remdesivir, which was now being allocated by the government in limited quantities. We were using tocilizumab much more rarely as we started to see more and more bacterial infections. And then we started to also use convalescent plasma occasionally from people who had recovered from COVID-19, as well as occasionally corticosteroids. And our approach in June has really continued to evolve. We're still using hydroxychloroquine in the context of a trial. We have better access to remdesivir, so we're using that more. And then tocilizumab still rarely, convalescent plasma a little bit more commonly, and we still don't know what to do with corticosteroids. So let's talk about a few of the specific agents. Probably the most controversial one right now is hydroxychloroquine. When we were early in the pandemic, it was really thought, based on some very limited initial in vitro data and a couple of small human studies with 20 or so patients in each arm, that hydroxychloroquine and chloroquine represented the standard of care for antiviral therapy. And we've learned quite a bit since that time. Since those initial studies and wide recommendation by a lot of professional societies, by our government agencies, there have been several observational studies that have been quite large that have shown no association between treatment with hydroxychloroquine and outcome. This is one from New York City that was published in the New England Journal of Medicine that looked at 1,400 patients, about half of whom were treated with hydroxychloroquine. There were some baseline differences between patients treated with hydroxychloroquine and not, but in this study, hydroxychloroquine was not associated with improved outcome, even after adjustment for a propensity score where they tried to match patients based on illness severity and other characteristics. Several of you may have seen this press release from the recovery trial, which was a UK-based randomized trial testing a number of interventions on an open label fashion against standard of care in patients with COVID-19. The hydroxychloroquine arm of the recovery trial closed, and the conclusion of this closure, which has not been published or peer reviewed yet, is that they were able to randomize 1,500 patients or so to hydroxychloroquine, which they compared to 3,100 patients randomized to usual care alone, and found no difference in 28-day mortality and no benefit in terms of other outcomes. There are some caveats, of course, whenever we're doing science by press release, which is happening a lot lately. These are just top-line results. They've not been peer-reviewed. The mortality that they were reporting without knowing the baseline characteristics is much higher than we anticipate in the US-based trial that's going now. This was also very high-dose hydroxychloroquine compared to what we're using, 600 milligrams times 4 over the first 2 days, and then 400 milligrams twice daily for 9 days, so a total 10-day course at a very high dose. And then it's unclear from the trial protocol, because this was comparing to standard care, whether open label hydroxychloroquine was allowed in the standard care arm. So it could be that this trial was a high dose versus lower dose comparison rather than a high dose versus placebo, like our trial that I'll tell you about is. So lots of caveats, and I look forward to actually reading the full manuscript when it's published. The trial that we're doing in the US is called the ORCHID trial, and this is a phase 3 double-blinded placebo-controlled trial. We're including patients who are hospitalized with confirmed COVID-19 who have some sort of respiratory symptoms, and we're excluding patients who have a QTC interval on EKG that's greater than 500 milliseconds, a seizure disorder, or a long list of potentially dangerous drug interactions. We're randomizing patients in a 1-to-1 fashion, hydroxychloroquine or placebo, and the dose that we've chosen is hydroxychloroquine, 400 milligrams BID for 1 day, and then 200 milligrams twice daily for 4 days, for a total course of 5 days. All the other treatment is per the clinical team, and the primary outcome is a COVID ordinal outcome scale, the same outcome used in the Remdesivir trial. We have a number of safety outcomes we're also monitoring. We've enrolled about 450 of a planned 510 patients and hope to have results by the end of the month. Tocilizumab is another agent that we're using. Many of our residents and trainees are calling this drug Toci, which I learned is the Aztec goddess of creation. So it's sort of become the nickname for this drug here in our hospital. This is an anti-interleukin 6 receptor antibody that's predominantly used for cytokine release syndrome in the context of CAR T-cell therapy, so not something that we use very often. This was thought to potentially be beneficial for patients with this hyperinflammatory late syndrome that some patients with COVID-19 will develop. We were using it for patients who had persistent fever and acute hypoxemic respiratory failure and shock who had a serum interleukin 6 level greater than 5 times the upper limit of normal. There's not a lot of data on this class of medications yet. There are several trials that are ongoing, and we look forward to a little bit more data here. Most concerningly, we did notice that as we started to use more and more of these medications, we were seeing many more patients with secondary bacterial infections. Unclear whether it was directly related to the use of this medication, but certainly gives us pause as we're blunting the normal host inflammatory response. And then Remdesivir. So this is from the ACT trial, which was just published a couple of weeks ago in the New England Journal of Medicine, or maybe a week ago. This is a placebo-controlled, double-blinded, randomized control trial that our institution participated in of adults with confirmed SARS-CoV-2 infection, and they had to have either hypoxemia and radiographically confirmed pneumonia. The intervention was Remdesivir for a total of 10 days, and the primary outcome was time to recovery, which was as judged by improvement on the COVID ordinal outcome scale. They had randomized over 1,000 patients at 60 sites throughout the US and found that patients treated with Remdesivir had more rapid time to recovery than placebo. This was a preliminary report. We're still waiting for all of the patients to achieve the 28-day outcome, and we expect to see a final report on mortality and other outcomes after that's occurred. And then finally, one of the pharmacotherapies that has been debated the most recently is whether we should be using anticoagulation in these patients. There are now lots of case reports and case series of potentially a hypercoagulable state with various phenotypes ranging from DIC to anti-10A deficiency or factor 10A deficiency, and frequent thromboembolic events of all sorts, both arterial and venous, ranging from venous thromboembolism, PE, and DVT to stroke and myocardial infarction. What we don't know is whether full empiric anticoagulation in terms of risk-benefit ratio is helpful for all comers with COVID-19. There are several trials in the US and elsewhere ongoing. We also don't know whether higher dose prophylactic agents are helpful as well. So currently, most of the US and international societies in critical care and hematology are recommending that at the very least we use routine prophylactic chemical VT prophylaxis, venous thromboembolism prophylaxis. We're using low molecular weight heparin as a prophylaxis for now in all patients. And we have a low threshold to look for clots in patients and initiate full anticoagulation if and when we find them. So what's been the experience at the University of Washington? Well, we, as of the end of May, had cared for 425 patients at our 3 hospitals with COVID-19. So compared to New York City and other areas in the US, our volumes were not that high. Of those, about 36%, 155 patients were in intensive care, and about 20% were on mechanical ventilation. Among all comers, mortality was 18%, and among those in intensive care, 30% and 31% on mechanical ventilation. So our outcomes are much better than are being reported in some other areas of the country and of the world that were much more resource constrained during this time, which makes everybody wonder whether some of those very high and very scary mortality numbers that were being reported were more related to system being strained by overwhelming numbers of patients than the disease process itself. So for this portion, hope to leave you with several take-home points. First is that COVID-19 leads to a fairly wide spectrum of respiratory illness, but on that spectrum is fairly classical ARDS. We are using a lot more non-invasive modalities for respiratory support, which I think can be considered with close monitoring and special consideration for staff safety. There are a large number of experimental medications that are being tested in trials. None of them are definitively cures yet, but many, perhaps in combination, may offer some marginal benefits in terms of small mortality reduction. This is our very first COVID ICU team that we put together as an extra team back in late February. And our COVID team now, because our volumes have gone so low, has been officially disbanded, and we're back to relatively usual operations, at least until the next wave comes. And thank you very much.
Thank you very much, Nick Johnson, for your presentation. It's really, really enlightening on the amount of studies that have actually gone on for COVID-19. So this is Dr. Nancy Ngumba will be doing the Q&A section. I'll ask a question that's been asked by Stanley's. For how long do you put your patients in prone position? For 24 hours, what's the duration?
Yeah, so for the non-intubated patients, we're doing much shorter cycles because most of these patients are just doing it themselves. And so we're asking them to lay in the prone position for 2 to 4 hours, as long as they can really tolerate, and then flip back into the supine position where they can rest for a little bit, perhaps eat. And then we ask them to go back to prone for 2 to 4 hours. And we'll do that until their oxygenation improves. for however many days they tolerate it. So for the non-intubated awake people, it's usually 2 to 4 hour cycles alternating with brief periods supine. For the intubated patients with moderate to severe ARDS, we pretty closely follow the protocol from the PROSEVA trial, which is at least 16 hours in the prone position. And these patients are usually deeply sedated. Some are receiving neuromuscular blockade as well. So we'll do 16 hours prone and then trial supine and see if their oxygenation worsens. And if it worsens, go back to the prone position for another 16 hours.
Thank you very much. Mercy is asking, does this apply to patients who have other respiratory illness? For example, an asthmatic patient. Have you had a patient who has another respiratory illness with COVID? And like for an asthmatic patient, how do you deal with them?
Yeah, this is a great question. And I think some of these therapies have to be tailored a little bit to the individual patient. We think that patients with underlying respiratory illness of various types are probably more susceptible to severe disease. And some of the things that we had been thinking about early on, some of the treatments for those severe diseases, as asthma is a good example, might contradict what we would do normally in COVID-19. So for instance, in asthma, we would often give nebulizers and steroids. Well, we didn't want to use nebulizers early because we were worried that they would potentially distribute virus into the rooms that these patients were in and put staff and other patients at risk. And we didn't want to use steroids early on in the disease either because there was concern perhaps that steroids would lead to increased viral replication like has been seen in other types of viral pneumonia like influenza, Middle Eastern respiratory virus, and the first SARS virus. So what we'd sort of been doing for these patients who have underlying disease and maybe exacerbations of their asthma or COPD is try to assess what we think is the dominant process that's causing their respiratory difficulty now. And if it looks more like an asthma exacerbation, to treat it more like an asthma exacerbation. Whereas if it looks more like COVID pneumonia, to really focus on the therapies we're using for COVID pneumonia. And some patients fall somewhere in between, and you just have to make judgments about which therapies are most appropriate. But these are very challenging, and these patients probably have worse outcomes than patients without underlying lung disease.
Thank you very much for that. Shafiq Hussein is asking, so is there a role of aspirin or NSAIDs like ibuprofen in the treatment for COVID-19?
Yeah, this is interesting. I think that this is another therapy that has the paradigm's totally changed. There was some reports early that ibuprofen specifically was associated with worse outcomes in COVID-19, and now some reports that perhaps it's associated with better outcomes. But we've not yet seen any high quality evidence either way. So I don't think we can say definitively until we have a trial about NSAIDs or aspirin that either of these agents are beneficial or harmful for that matter.
Okay, thank you. So there's a question here from John Mukoma in terms of physiotherapy for these patients, whether intubated or not intubated. Is that something you would advocate for or not, or based on the management that you've actually done at Seattle? So what usually happens?
Yeah, this is a really good question also. One thing we've noticed for these patients, as I alluded to early on, is that the ones who become critically ill are often sick for a very long period of time, and their recovery is quite prolonged. And another thing that we're doing for these patients is trying to limit the number of staff who are exposed to them to try to reduce the risk of staff getting sick. And this has resulted in us not doing a lot of the things that we routinely do for people who are critically ill, one of which is very aggressive physiotherapy. And I think that probably these patients would really benefit from very early, very aggressive mobilization, even when intubated, and aggressive physiotherapy. But we've been a little bit limited by some of the infection control procedures that we're using to limit who comes in and out of the rooms with these patients. And so I think that there would be great benefit, but my suspicion is that patients are actually getting less physiotherapy than we were offering to similar patients before COVID-19 because of the infection control issues, unfortunately.
Thank you very much, Nick. There's a question here from Alan Kochi, who's interested in knowing, at the time of intubation, have you ever gotten a few patients who crash at intubation, and is CPR advocated for in such a case? And then would you like comment also on the initial ventilation settings and how soon you consider weaning off?
All very good questions. So I think that these patients often have peri-intubation profound hypoxemia and desaturation, and I've seen that in virtually all of the patients that I've intubated. The reasons for that are several. One is that they have significant shunt physiology and a lot of atelectasis and de-recruit their lungs very quickly. And so many of these patients that I've intubated, as soon as we administer the intubation agents, the induction agent and the neuromuscular blockade, they desaturate profoundly. And so we are using positive pressure ventilation via bag valve mask or via CPAP around the time of intubation to try to maintain recruitment and prevent this peri-intubation hypoxemia. But still, a lot of them do have profound hypoxemia around the time of intubation. I fortunately have not personally witnessed a peri-intubation cardiac arrest. There has been one in our system. And, you know, these are really unfortunate events. And I think that the whole question of whether to do CPR in COVID-19 really hinges on what are those patients' chances of having a reasonable outcome after CPR. And I think of these patients very similarly to how I think about other patients in whom I offer CPR, which is if they're young and healthy and have predominantly single organ dysfunction, and CPR is within their family's stated goals for them, then we offer CPR. But for patients who are older and have many comorbidities and are unlikely to survive, if they develop cardiac arrest, we typically have very frank conversations about whether CPR is appropriate or not for that patient with the family, and typically don't offer CPR in those situations. And then the last question was about vent settings. So my initial vent settings, I just assume that all of these patients will likely meet criteria for ARDS when they're put on the ventilator. So I will typically set them at a tidal volume of 6 milliliters per kilogram based on their predicted body weight, which is again based on height and sex, and then set a respiratory rate to try to match their pre-intubation minute ventilation, which is usually on the higher side, so perhaps 25 is a good starting point. I'll usually start at a PEEP of 5 or 8, and then titrate the PEEP up or down based on the patient's hemodynamics and oxygenation and compliance. And usually start at an FiO2 of 1 and titrate down very, very rapidly. So those are my initial typical ventilator settings.
Thank you very much. For people who have raised their hands, feel free to unmute yourself and ask your questions. There's a question from John Wanjuki, who's wondering whether there are chronic lung complications post-COVID-19 pneumonia. Based on your experience, have you seen any further lung complications?
Yeah, I think this is something that we're all waiting for and anticipate that the answer will be yes. I don't know that we're far enough out yet from our initial wave to really know what the chronic lung disease of COVID-19 will look like and what recovery at the 6-month or 1-year mark will be for many of these patients. We have seen some patients coming back to the hospital or back in clinic, and even 2 or 3 months out after their initial illness still have profound exertional dyspnea and fatigue, though I don't think we have any patients far enough out to be able to comment on long-term complications. I suspect that there will be a subset of patients who have persistent restrictive lung disease due to fibrosis, but hard to say at this point because we're so early in this process.
Thank you very, very much. So there's a question on whether you have any experience with dealing with COVID-19 in children, or this is just based on the adult population.
Good question. I primarily care for adults. We have a dedicated children's hospital in Seattle, and they have seen several cases of COVID-19 in children. What I hear from them is that the respiratory illness tends not to be as severe, but there have been some unusual systemic complications, including a Kawasaki-like syndrome that's being reported, and they've seen several cases of that as well. But I personally don't care for children in the intensive care unit.
Thank you so much, Dr. Johnson. This is Rhoda again.
Hello.
And thank you, Nancy, for taking over the Q&A section. And I liked your presentation, but I'd love to hear from the team that developed the Kenyan guidelines so that we can compare and see what we're doing. I can see you're doing quite a lot. You're still doing the hydroxychloroquine trials, but limited, and you're having limited remdesivir, as you said. You're having convalescent plasma and occasional corticosteroids. Then you have anticoagulant therapy. So I would love to hear from Dr. Maritim about
Dr.
the Kenyan
Kalondu.
guide. Yes.
Could I say something? Could I ask something before Dr. Maritim is admitted?
Yes, you can ask.
Yeah,
How are you?
I'm fine. My name is Anguche. Just like you, Dr. Johnson, I'm a critical care specialist in Germany. And there are a few comments I'd like to actually make to this. First of all, your presentation was brilliant. It was like a miniskirt, I would say. It was short enough to provoke excitement, but long enough to cover the essentials.
Thank you.
Having said that, what you said, I'd just like to cement what you have said. This COVID disease is actually a multi-systemic disease. It touches on every system. My only problem is, for example, this Remdesivir study that you mentioned that was recently published in the New England Journal of Medicine, upon which Dr. Fauci made a recommendation, an early guarded recommendation about this drug. I must say that the numbers did not impress me, because we are talking about, first of all, the guys who seemed to be improving, the guys, the shortening of the illness, 11 days versus I can't remember how many days, not needing oxygen and so on and so on. We all know that the development of the disease between day 8 and day 16th, that's when the drama happens. And for the people who are going to actually survive this period of time, they could climb Mount Kilimanjaro, they could drink a cognac, and then we would necessarily say that that's what caused them to actually get better. So for me, I would still I take the German position, and it's the same position we took when our Chinese colleagues were telling us that we should adopt the early intubation strategy. We said, wait a minute. When I see a saturation of 80%, that is a quarter of the story. It's just, and the picture, I talked about this picture earlier on of this lady lying on a bed. She is looking at her mobile, probably her Facebook, and she has disastrous saturations. Why? Because it's a quarter of the story. You haven't talked about her cardiac output. You haven't talked about her carriers of oxygen, the red blood cells. You haven't talked about her acid-base balance, which determines how that oxygen is going to be given up into the cell. And in the cell, intracellularly, you haven't talked about the mitochondria, how they're actually using this oxygen. So oxygen alone, the saturations alone, cannot and should never determine if I'm intubating a patient or not. And this is something we actually said here in Germany, and we were not going to intubate patients early. And if you compare our mortality, general mortality in Germany is comparable with yours in Washington, in Seattle, because you have about 30% intubated mortalities. We had slightly under that. So I would like to say that again. I think supporting this patient is the most important. And secondly, all these medications that are being suggested as being therapies for COVID-19, there is no satisfactory evidence out there. It's just a matter of we do not have anything better so they are worthwhile. And I'd like you to comment about hydroxychloroquine and arrhythmias and coding when they're combined with macrolides.
Yeah, great comments. I agree with you completely. This is a multifaceted, multi-system disease. I don't think we're going to see a single drug that's a cure or that causes dramatic improvement in outcome. I think we may see a few combinations of things give us marginal gains of a couple percentage points here and there. But I think the crux of taking care of these patients is really excellent, comprehensive critical care and not a single drug. So I 100% agree with you.
Answer this question.
I think with the Remdesivir, I agree. I'm not super impressed by the initial results of the ACT trial. I think that it sort of, for me, feels very familiar to oseltamivir, to Tamiflu, whereas the benefit of Tamiflu is minor. It's a short reduction of symptom duration. I do wonder if combined with some of these other anti-inflammatory therapies, we may see a sort of cocktail of drugs that eventually gives us some reasonable improvement in outcome based on this bed of really well-supported critical care evidence that we're applying to these patients, which I think is the crux of what we're doing. And with regard to hydroxychloroquine, absolutely there are reports in combination with azithromycin or at very high doses in the Brazilian chloroquine study of adverse cardiac complications. In our trial, we've done 3 interim analyses at the lower doses, not combined with azithromycin. We've not seen significant cardiac manifestations. So it may be related to dose or combination with other drugs. Hard to know at this point. Thank you for your questions and comments.
Thank you, Dr. Anguche. Thank you, Dr. Johnson, for that response. Now, Dr. Johnson, I'd love us to hear from the Kenyan team that developed the COVID management protocol so that we get a feel of what was prescribed. Most of our patients, the ministry told us around 88% of our patients are asymptomatic, which is a good number. So I would love to hear from Dr. Mari team, what are we giving our patients, what is prescribed in the guidelines, so that as we leave this session, as we end this session, everybody who's listening from whatever part of the country is not going to be busy buying Remdesivir and hydroxychloroquine for their patients. Dr. Mari team.
Yeah, good evening, everybody.
Good evening.
Thank you, Dr. Johnson, for that excellent presentation. Thank you, Dr. Anguche, again for your experience from Germany. So just a little bit about our Kenyan experience. Most of our patients currently are presenting with asymptomatically or pre-symptomatically, and some few patients have another large proportion of patients have mild symptoms. A small proportion of our patients are presenting in the range of severe critical illness. And those are the patients who have ended up losing their lives. A few have been saved when they went into ICU and received support. So in terms of current therapies, in our national guidelines, we currently do not recommend any treatment because we know there's no confirmed definitive treatment. Most of the currently existing therapies are experimental, and therefore any treatment that is to be given is in the setting of a clinical trial. We have signed up to participate in the WHO Solidarity trial, and that's a clinical trial that tries different kinds of therapies ranging from Remdesivir, lopinavir, ritonavir together with interferon beta 1A together with hydroxychloroquine. So it's a clinical trial that is awaiting approval from the regulatory authorities so that we can start it. But currently, you cannot give any patient any of those treatments without reporting to the Pharmacy and Poisons Board. So whichever patient you want to give any of those treatments, then you need to do it in the setting of a clinical trial where you monitor the patients, make sure that they meet a certain profile, ensure the safety, ensure pharmacovigilance even as you follow them up for the duration of the treatment. So currently, there's no recommended treatment, and we've always emphasized this even in our Friday morning sessions. Some some of our colleagues, I think, initially for the very sick patients have tried certain therapies like tocilizumab, but again, with under strict follow-up and care, and they had challenges. Again, some of the patients developed hepatitis or untoward effects, and they had to discontinue the treatment. So what the message I'd like all of us to keep in mind is that none of these treatments are licensed or are approved for COVID-19 in Kenya. Some of the therapies already exist and are used for other indications like lopinavir for HIV treatment. We don't have remdesivir even licensed for use in Kenya. It's a new treatment that has previously been used in trials for Ebola, but now it's being used under compassionate use for COVID-19, and we've seen the publications, and Dr. Johnson has mentioned them, but none of these treatments you can give a patient without reporting to the PPB, which is the main regulatory authority. So we are waiting approval, and several hospitals have signed up to be part of the Solidarity trial. So we use it in that setting and generate our own data. And it's a rigorous process because we already know the safety concerns, particularly for hydroxychloroquine, where there's the QT prolongation. So it means some of the patients, we have to select them carefully and follow them up and make sure they don't develop the cardiotoxicity that's associated with this. So I just want to stop there. Okay, in terms of ICU care, as we continue with the outbreak and we are anticipating a surge of cases, what we know, and we've seen clearly from the and Dr. Anguche has mentioned this severally, your ventilation is not definitive treatment, it's a supportive treatment as the patient recovers. So even as we look and we know the number of ventilators we have in the country, we're looking at a way where we can increase the oxygen or oxygenation support for the patient. So working with facilities to improve their capacities, increase their oxygen. For example, for facilities that are able to invest in oxygen plants ahead of the surge, this is the direction that we are really heading towards, so that we are not really necessarily looking at ventilators per se, but being able to provide supplemental oxygen for those patients who present with severe hypoxemia, and together with what we've already learned about prone ventilation, maybe invest, if we can, in the high flow nasal oxygen devices, but we've seen even in Seattle, they don't have too many of that. So again, looking at ways in which we can support our patients when that time comes. Let me stop there, please.
Thank you very much, Dr. Maritim, for clarifying that and clarifying the mode of treatments that we're using for our patient. And as you've heard, please don't go and prescribe this for your patients. If you must do, please, you know the proper channels to prescribe this medication through. Dr. Waruru Mugo, there's a question I saw that you said you'd like to answer live. Hello, Dr. Waruru Mugo. Hello, Dr. Mugo. Okay, as you wait for Dr. Hi, there's a question that I saw you'd like to answer from Soita. And he was asking about use of high frequency ventilation modes in these patients.
No, I think I was checking the one or the nebulization, because that's the area we're having the challenge right now in children.
Yes.
Where we seem to have withdrawn that, not the one for the high flow, because I think Dr. Gucci from Germany had touched on that.
Okay.
The nebulization. Like to
share more? Yes, about the babies, the children.
Yeah, the nebulization, even with those children with bronchiolitis and a bit of mild to moderate asthma, we are getting very skeptical in terms of using a tribulary the way you used to use it in the office or even in the ward. And we are only limited to very, very few cases like very severe bronchiolitis or very severe attack, on account that if we do not have the results of the COVID, we care for the members of staff or the members of the family if it's at home. So we are getting away from that and moving towards more of the MDIs and the chambers. That is the only shift that we have had recently. Like now, since about the last 2 or 3 months, We have done about only like 2 nebulizations, even in very severe situations in outpatient. Thank you.
Thank you. Thank you for sharing that experience with us. Dr. Christine Gishui. Hello, there's a question I saw you wanted to answer live. Hello, Dr. Christine Gishui.
Oh, I'm sorry, no, there was no question.
Oh, okay, because I saw you had said you'll answer live the question for prone ventilation in intubated patients.
No, no.
Okay, I guess that was a bit of an error. Let me see, is there a, there's a Dr. There's Dr. Abram Omambia. Maybe Dr. Kinuthia can enable him to say something or share something. Hello, Dr. Kinuthia. Hello, Dr. Kinuthia.
Yes, I have enabled him.
Okay, let's wait for him to. Hello, Abram Omambia. Hello.
Hello? Hello? Hello?
Yeah, hello, go ahead. Please share what. Yes.
How are you, everyone?
We're very fine.
I've seen you've referred to me as a doctor, but I'm not here. I'm not a doctor. I'm just a researcher. I really did a good work on COVID since February, and I've seen, and I have a very important, I think a paramount concern based on hydroxychloroquine. I really think, according to the chemistry of this product, as a chemist, I'm an analytical chemist, it's a little bit, in terms of its pharmacodynamics, it really depends on the pH. It is really affected by the pH of the body, the fluid. So I was thinking, according to my works, the hydroxychloroquine should undergo a derivatization. Hello?
Yes, Abraham, please make it brief. What is the question or the comment? Okay, we seem to have lost him. Thank you, and we'd love to hear more about the study that you're doing and the research that you're doing. Maybe when you get time, you can let us know more about it.
Rhoda.
Yes.
Rhoda, Professor Nduati wanted to say something.
Oh, okay. Hello, Professor Nduati.
Hello, good evening.
Good evening to
and,
you.
Thank you to the presenter, Dr. Johnson. And my question is actually to him. You presented your case, the case presentation was a woman aged 32 years. How often are you seeing this kind of patient, this profile of patients coming in with the COVID infection and actually needing respiratory support? Were there any particular risk factors for this particular client?
Thank you. Yes, great question. As you probably have seen from a number of the large case series in the US, the majority of patients who are dying from COVID-19 in the US are typically older with medical comorbidities. The average age in Seattle of patients who were admitted to the ICU, it was 63 years. And I don't have a distribution for you in front of me, but we have had quite a number of younger patients in their 20s and 30s, some of whom had essentially no comorbidities, including several healthcare workers. So we are seeing occasional younger people like this patient, but the majority of patients who develop critical illness tend to be a bit older and tend to have several medical comorbidities. For us, the most common are hypertension and diabetes.
In relation with that question, I'll ask a question from George Owiti, whether you have any experience with gravid patients in terms of either the non-intubation or the intubation mode of therapy?
Personally, we've not taken care of any pregnant patients in our intensive care unit. The way that our health system is divided is that the obstetrics hospital is actually separate from my hospital. And so we just don't have obstetrics here at my hospital. So our system has seen several, but not me personally. From what from talking to my colleagues who work at our other hospital, our approaches to management are quite similar. Obviously, depends on where the patient is in their pregnancy and what level of monitoring and support needs to be provided for the fetus. But our approaches have been fairly similar for gravid patients.
Dr. Kalondu, let me one additional. I guess you don't ask this, but maybe we should start asking women-related questions like use of hormonal contraceptives. You know, this may modify disease progression in young women. Thank you.
Thank you very much, Professor Nduati. I think we're almost coming to the end of the session. Most of the questions that people have asked in the Q&A have actually been addressed either in the PowerPoint presentation or with the questions that were being raised. I'd like to give Nick some time to give us his parting shots, his final comments before we end the session.
Well, thank you. I first of all just wanted to thank you all for taking the time relatively late in the evening to have this conversation and to learn about our experience. I was really looking forward to and really enjoyed to learning a little bit more about what your experience has been. And I think one of the unique things about this disease is that we've had an opportunity to learn from colleagues all over the world, and I think have really grown stronger as a medical community, learning from colleagues elsewhere in the world. I think my one parting thought is that I think this is a disease that people can survive with a reasonably good outcome. I was certainly concerned when I heard reports of mortality in excess of 60 or 70%, in some places 90% for patients who required intubation and mechanical ventilation. But I think we're starting to learn that just with good supportive care, with the types of care that we've provided for so long, that patients can survive and do survive. And we've had our share of victories and a lot of loss as well, but a good share of victories here in Seattle where we've seen patients leave the hospital in relatively good condition. So I'm optimistic that whatever lies ahead for us in terms of additional cases that we expect to see over the next year or longer, that we've now developed systems to be able to care for these patients, and hopefully we'll continue to see relatively good results and maybe even better results as we learn more and more. Thank you all for having me, and it was a pleasure learning from you all as well.
Maybe before we end the session, I'd like to give Dr. Thuranira to ask his question. Dr. Thuranira?
Actually, it wasn't my question. I've just read it in the chat. Nick, what is your experience about home-based care, and what would be your comment about it?
Yeah, as an intensive care physician, it's not something that I spend a lot of time thinking about personally, but our health system has certainly been doing a lot more telemedicine and home-based care than we ever had before. I think some of the trends that have come up in the US have been home-based pulse oximetry and symptom monitoring for patients who are being treated at home. And in a lot of settings, it's been very successful, keeping patients and families relatively isolated in their homes and providing telemedicine monitoring and pulse oximetry so that they can monitor their symptoms. So I think it's feasible. It sure would have been nice to have a system set up to do that effectively before COVID-19 rather than to have to set that up in the face of a pandemic. But I think that is a key component of COVID-19 care, probably for the majority of patients, is to keep people and families self-isolated and able to manage their symptoms and care at home.
I'd like to give a warm thank you to everyone, all the attendees who've actually taken their time to join this session. It's a night here in Kenya, so thank you very much for actually attending the session. For Dr. Nick Johnson, thank you so much for sharing your experience with adult management of COVID-19 in critical patients. And I am very sure most of us have learned a thing or two in terms of how to manage such patients. We've actually come to the end of the session. Thank you very much. Have a good morning for Dr. Nick and a good night for all our attendees. Thank you.